Hello, I'm sorry. I think I was muted. So, yeah, I apologize for starting so coming in so early. I have to drive to Seattle. I was
Oh yeah,
trying to
no
make sure
worries.
that I joined before the meeting started. I didn't know that I would get let in so
Oh
quickly.
no worries at all. We just gonna
Yeah.
you're we're gonna have some other people joining to kind of talk about work just the setup piece and all of that piece. So, but no worries, no worries.
Okay.
I totally get it.
Okay.
Cool.
Okay.
Welcome.
Thank you.
Yeah.
Thanks.
Just too small.
Hello. Thank you everyone for coming here to our listening session. Just a quick reminder before we get started. You do not need to have your camera on unless you're actively sharing and want to have your camera on. So cameras are optional when you're sharing. You don't have to have a camera on now. And it's 5 p.m. So let's get started. Before I start though, I would like to start us off with a land acknowledgement.
I'm gonna get some soda.
And before I do that, let's make sure that everyone is on mute. All right. So my name is Ashley Bell, and I'm in West Olympia, the traditional lands of the Coast Salish people, including the people we know today as the Nisqually Squaxin Island and Confederate tribes of the Chehalis Reservation. I honor their ancestors and leaders who have been stewards of this land and water since time immemorial. We acknowledge their stewardship, their forced removal, and their continued fight to live on their ancestral lands. Welcome. So I'm showing that we have a lot of interest in this session today. And so Dan, will you go ahead and pop up the PowerPoint? And I'm on slide 3. And so today we're going to do a brief overview before we get started, and then we'll get right into it. And so with that overview, I'll go ahead and introduce the facilitators today. So my name is Ashley Bell. I'm originally the Behavioral Health Program Coordinator, and I am the lead for implementing this 5229, which is health equity. I'll go ahead and pass it to Omar to introduce himself.
She's doing good. She's making progress.
Hi, good afternoon, everyone. Omar Santana Gomez. I use he, him pronouns, and I am the Equity and Social Justice Manager that's working with Ashley and the other folks on this project.
Dan.
Hi there, I'm Dan Frank. I'm a management analyst with the Washington State Department of Health in the Health Systems Quality Assurance Division. Welcome, everybody.
Okay, and then we'll go over to, we'll start with Hope.
Hi, I'm Hope Kilborn, she, her pronouns. I'm the co-policy analyst on this project. Be here.
All right, and Ross.
Hello, everyone. My name is Ross Valore. I'm a policy analyst with HSQA, and I use he, him pronouns.
So before we begin, really getting to the meat of things, Dan, do you want to do an overview real quick on how to use Microsoft Teams?
You betcha. I could do that, no problem at all. On Microsoft Teams, I believe what the process is going to be, if you do want to share, what you can do is on the top portion of the screen, you should see a thing where you can raise your hand. Should be next to where you could, I think it says show conversation, and next to that, a place where you could raise your hand and lower your hand. You could also type in comments and questions into the chat box. That will work as well. And that's as simple as it gets. We just ask it, like at any meeting, that if you're not speaking, that you make sure that you're muted. But that's pretty much it in a nutshell. Does anybody have any questions, or did I confuse anybody? Ashley, it does. We could do that piece if you'd like. But most of the time when people speak, it usually converts over to them being able to be seen as they speak.
Yeah, with the spotlighting.
Yep. Perfect. Well, welcome everybody. Appreciate it.
All right, so we'll go ahead and move on then. And so it's just a little bit of housekeeping before we begin. Please keep in mind to be respectful. Please be mindful of everyone who's in here, whether they speak or not. There's over 80 people in the chat today. So it doesn't matter if they're muted, if they're being seen on camera or not. It doesn't matter if they're sharing or not. We need to stay away from offensive comments. If you do give any offensive comments, we will mute you and have a conversation later. We want to create a safe space as possible and give individuals the room to share their experiences without interruption. If you wish to share, like said before, please raise your hand and staff will unmute you. You are not required to show your face when sharing. And if you feel more comfortable, written comments are accepted. This is a large group of individuals. Staff will try to monitor the chat right when the chat happens, but it could move really fast. Staff will also provide feedback when appropriate. And if needed, we'll follow up with you. This meeting also has a limit on the size and as well as the time limit. And so as a result, we'll ask you to be aware of the time and the time limitations. We have gauged how many individuals are in this meeting, and based on that, set a time limit around that. And so today your time limit will be 2 to 3 minutes. We'll go with 2 minutes to begin with, based on how many people raise their hand to share. We are willing to stay a little bit later tonight if we need to, but also I will say there are some other listening sessions scheduled if you have something to say and you didn't get a chance to say it. As always, we also welcome written comment, which will be provided at the email, and I'll make sure to put that in the chat for you. And also, if I have to, ask you to finish your thoughts because of the time limitation, you can also continue with your comments in written form. Lastly, please remember this is a listening session, so we'll be addressing our rules during our rules process during a workshop at a later date. Today is just to listen and to learn. And if you begin to talk about the rule process, we'll ask you again to quickly finish your thoughts. Surveys. And so moving on, I wanted to talk a little bit about surveys, and we will ask you to submit to an optional voluntary survey. And what we want to do is we really want to gauge our ability to reach individuals and change our tactics if we need to. We want to make sure we're reaching out to a diverse group of people. And if we are missing a group that needs to be invited to the table, this survey will help us recognize that. We'll use this information to make further changes to how we reach out to groups of individuals who are not here at the table as well. And the survey was crafted over time. We wanted to make sure that we get the most amount of data out of the fewest questions and the ability to preserve your identity. This is anonymous, but of course, if you were to share identifying features such as your phone number, your address you live, or your name, we wouldn't be able to guarantee that, that identity. This survey and the answers are subject to public records requests, but as long as you don't use any information that identifies you, you should be okay. And if you don't feel comfortable answering a question, you can always skip over that question. In fact, you can decide not to take the survey as well, especially if you're feeling uncomfortable. We will also post the survey link in the chat, and if you are willing to take the survey, it should take 5 minutes or less. If you need help, we will gladly provide assistance. And so I think the PowerPoint, I'm ready for that, Dan, and then I will put the links in the survey. And so,
Hi, Ashley.
Go ahead.
Hi, sorry to interrupt. Is it okay if I also introduce the ASL interpreter?
Oh, yes.
Hi, Mary, are you on with us?
Hi, I'm here. Yeah, can you see me?
So I can't see you if your camera is on.
It is.
Uh-oh.
Let me go
I can
ahead
see you,
and-
Mary.
I
Okay.
see you.
Great.
I can see
When
you.
I'm, oh, great. Perfect. I see that I was just spotlit. Great.
Oh, awesome. Thank you. Yes, and also just to note too, if folks are not speaking, if you could also turn your camera off. That way we have more space for our ESL interpreter to be able to interpret while we're speaking today. All right, back to you, Ashley. Thank you.
All right, thank you for that. Let's see. So I wanted to share a little bit, why we're here. Section 2 states what is health equity, and I do want to state real quick. I think this is important. Someone in the chat said the ASL interpreter is not visible to me, and Mary, I cannot see you as well. Is your camera on?
Hi, yes, my camera's on and it is telling me that I am spotlit. I also see that Danielle Jordan told me that she can see me. So I'm not sure what's going on. I see Shailene also says can see. Marianne says can see. So a few people can see me. Seems like some other people can't. Not sure why.
Dan, will you?
Yep, I'm going to do some troubleshooting here.
Okay. And so there's some feedback in the chat as well.
Oops, I just saw myself disappear.
I'm doing some troubleshooting, Mary, so that was on me.
Got it.
All right. So I will continue on in hopes of time here. So this bill is all about health equity. All right. And so health equity exists when all people can attain their full health potential. They're not disadvantaged from achieving their full health potential because of factors such as race, ancestry, disability status, the neighborhood you live in, all those things. And equality and equity are not the same. In fact, equality gives everyone the same resources, while equity gives people the resources they need to obtain the same opportunities. Health care or health inequities have always existed and have been a part of the healthcare system. And this COVID-19 pandemic has really highlighted that. And so what this bill does is it was passed by Washington State Legislature in 2021, and it requires that healthcare professionals must take continuing education. The goal is to help providers think about their own impact on others. And this can change how providers work with others so that they can reduce health inequities. So what do we need? Well, we want to learn about health experiences with health inequities. We better want to learn how it harms individuals and be aware of its role in the health system. We want to recognize where the health system can transform. And we really just want to hear from you. And so with that, I'll be quiet and I'll hand over the meeting to Omar for the listening session.
Thank you, Ashley, and hi, everyone. So we can go to slide number 13. And so as Ashley described with the implementation of the health equity bill, we're trying to gather information from the community about stories about people accessing healthcare, having issues with accessing healthcare. And so just as a prompt, and I think we're going to kind of turn it over to the participants today. But these are kind of prompting questions to allow folks to get an idea of kind of the information that we're looking for. But please, if you have stories to share, that's kind of what we're here for today. So what I'm going to do is I'm going to read the questions for us. And then as we see hands, we'll start calling on people to kind of share with us. And we'll allow the team to kind of gauge timing, but we'll try and allow people to talk as much as we can. And so question number one, what does equity mean to you? And kind of like the way that Ashley kind of described what we're looking for as far as like what health equity means. What are your experiences with health inequities and how have they affected you? Number three, how can healthcare professionals improve so that they are providing fair health care? And then finally, is there anything else Department of Health needs to take into consideration? And so these are the prompt questions. We will leave them up. And so if any folks, I see some hands up already. And so I don't know who might be gauging as far as who we should call on. I'll leave that for the team.
Okay, I will just go through my list, and the first person that we will unmute is Daniel Jordan. Go ahead, you have the mic. Or, let's see. Dan, I might need help getting her off of unmute.
Hi, so are we only answering one question? The first question?
No, sorry. So the questions are there
Okay.
more of as a prompt, and you can kind of
Okay.
take whatever question. Yeah.
Okay. So I wanted to join this call just to kind of talk and share my story. I know I have 2 minutes. So I'm obviously an African-American woman. I'm 36 years old, and I've had an unfortunate number of experiences where I've had to get health care between emergency care, and then I'm a cancer survivor, so cancer treatment as well. And I would say the biggest kind of failed expectation that I've had repeatedly with the healthcare system is not being heard. The first experience that I had that was pretty negative was I had just a lump in the back of my head and my scalp. I had to have surgery. It was outpatient surgery. I went to the clinic. The surgeon was cutting my head and I could feel what she was doing. I told her that it was hurting. Excuse me. I told her that it was hurting. I told her it wasn't numb enough and it was painful. Obviously, your scalp is one of the most sensitive parts of your body. She didn't listen to me, and thankfully, my mother was in the room for the procedure, and she had to actually kind of get aggressive and advocate on my behalf before they were willing to numb the area more. After they finished my procedure, there was blood caked in my head. The front of my shirt was completely covered. They didn't gown me. They didn't wrap me up enough. They literally sent me out of the room. I was dizzy because of how much blood I lost, and they had my mom wash the blood clots out of my hair. And this was at Cascade Eye and Skin Center, so it wasn't, somebody's basement. The second experience I had was after my tonsils were taken out. I went to the emergency room at St. Joe's, and I was literally throwing up blood. There was blood shooting out of my mouth, and I had to wait in the emergency room for a significant amount of time with blood clots forming in my neck. My breathing was getting cut off, and I was talking like this, and I told them that I couldn't breathe, and they still didn't take me back into a room for a significant amount of time. And the final thing, which is kind of the worst, is I went to my doctor starting in probably the end of 2019 and was telling her I was having severe pain in the right side of my breast. I had a large lump and I was concerned about whether I had cancer, and I wanted to have a mammogram. Unfortunately, it took until July of 2020 for her to admit that maybe my condition or my case was serious enough for her to warrant ordering a mammogram. And I found out that I had stage 3, grade 3 breast cancer. It was spread almost to the margin of my rib cage, and I had to have a bilateral mastectomy. And I could have had I waited or had I not insisted, I probably would have had stage 4 cancer and, wouldn't be alive. So I really would like to see, first of all, healthcare providers existing, getting more education and developing some empathy for people that don't look like them. And I also would like to see initiatives to bring in more diverse people into the healthcare field, because I think a lot of times if people don't look like you, it's hard to relate to them. And it's frustrating being a woman of color. You know, I've never had a physician who looked like me. So that's what I wanted to share.
Thank you, Danielle, for sharing.
The next hand up I have is Lyndon Jordan. Dan, again, I might need help unmuting participants.
They should be able to unmute. Can you not? There you go.
Hello.
There you are.
Am I on? Okay,
Yeah.
thank you. Thank you. First of all, thank you for giving us this opportunity to speak with you. I am Lyndon Jordan, he, him. I'm here on behalf of PFLAG Skagit and the Washington Gender Alliance. And I think it's nice to be able to follow Danielle because some of her same concerns, the population I'm representing has the same concerns. Like to speak specifically about transgender adults, adolescents, and children, anyone who's non-binary or somewhere else on the gender spectrum. When I think of health equity, I think of care that is competent, compassionate, accessible, and respectful. And we do a terrible job in this state of all of those when we're talking about trans folks. It is the whole thing about if you don't look like me and I don't look like you, the healthcare just goes south. We need more training. We need training from our medical care providers in working with trans people, with non-binary people. We need training for receptionists, for when people come in. We need forms that represent all of us, not just male and female, and that is still a huge problem in this state. I sit and I listen to trans women talk all the time about the horrendous experiences they have going for healthcare. They are misgendered, they are insulted, they lay in emergency rooms and hear nurses tittering and making comments about their appearance out in the hallway. This is completely unacceptable, and I do believe that training would help a ton. There are trainers out there who are working with healthcare providers. We need some kind of an emphasis like this bill represents to encourage people to do that sort of training. We have very few people who will work with kids, and we are desperate for people knowledgeable in pediatrics who can work with kids going into adolescence when they are identifying as a different gender than their assigned gender at birth. Work with families, help families deal with this. I know we're talking about health equity. I'm going to put mental health care under this because we are desperate also to have good, competent, respectful mental health care. So thank you for taking all of this into consideration, and good luck.
Thank you for sharing.
We have Dr. Larry Jones. Go ahead and unmute yourself.
Hi there. I am an optometrist and a hearing specialist of color. I'm a Native American, Black, African American, also Irish and English. So I'm kind of a mixed up person. I grew up in West Olympia, so I'm glad that you're in that area. I went to high school there, so I've got experience with exactly what Miss Jordan was talking about, and also the Jordan right after that. Implicit bias happens with practitioners, and it happens with all practitioners, whether it's black, white, yellow, or red. We need to know ourselves what we're doing wrong, and those are diversity issues that should be addressed in continuing education and should be required by each state. So these courses of implicit bias are being given where we can train doctors to understand why our minds are doing these reactions to patients when they should be treated better. We don't treat them correctly. And I'm saying we as doctors, I understand what implicit bias is, and so I've worked through that. But we definitely do that. I teach a diversity course myself, but this is important, and very, very, very important, because people are literally dying. Just like Ms. Jordan said, people are literally dying because of these health inequities. And so I believe that that's one of the most important things. I myself have come on to speak about the eye doctors are not getting paid to dispense state glasses for DSHS. So I've been I looked at my numbers, I did probably close to $3,000 worth of work, and I got paid $200 for what I did. So all of the doctors have quit dispensing glasses for kids and adults because they aren't getting paid. So I'm one of the only ones left, and it's hard keeping my employees because we're so busy and trying to make those numbers work. They're not. So we implore the state to actually start paying for dispensing and paying more so other doctors will want to do this. So this is something that I am just I'm pleading for right now. The people around us, all of the indigent people that are needing help, that don't speak English as well. And I see 80% DSHS in my practice. So it's really important that we get people to be able to see. And so I'm just imploring the state to do that. Thank you.
Thank you.
Thank you, Dr. Jones, for sharing.
I have Denise next.
Hi, can you hear me okay?
Yes.
Awesome. Thank you very much for this opportunity to speak. And I'd like to acknowledge the people that have already spoken that have shared some really important stories. And I hope that we do take all that into consideration. I consider myself a fairly privileged person. I'm white, I'm middle class, I have some financial resources available. But I'd like to share my experience as the parent of 2 children with special needs and the barriers that we're seeing, because I feel that if they're impacting us, that they're going to have even a larger impact on people from other marginalized communities. First of all, I have a younger child that is trans and non-binary. And so I'd like to expand on the previous comments that we had on those topics, say that it's very hard in the current system for him to be not misgendered and for his real name to be recognized. We have not had the opportunity to go through a formal name change yet. And so medical records, insurance records, the forms that are used in all the different medical offices refer to his gender at birth and his name at birth. And even when they will add notes to the file that says that he has a different preferred name, those are usually not the names that is recognized on different screens. So when he gets called for an appointment, when we call to make an appointment, when we fill out forms, he has to misidentify himself and use a name that is not his own. And that is really traumatic for him. And so I think we need to really consider how we gather and keep that information and how that impacts people. Additionally, I'd like to talk about some of the issues that I've encountered with my other child. She has a number of different comorbidities, and the biggest roadblocks that we have hit have been around behavioral health. As the previous doctor said, issues with DSHS, we have the same issues that are happening with state-funded behavioral health. She is currently on Medicaid and gets her behavioral health insurance through the state and through Medicaid. And there are almost no practitioners in our area that will even consider taking that insurance. We have had to private pay for any mental health benefits that we get because the practitioners will not work with Medicaid. The process really needs to be looked at. These people that are on state-funded insurance, we need to look at if providers are not accepting that insurance, why are we not paying the right amount? Is the process to get on with the state too complex? Are the forms too complex? There are a number of different reasons that providers do not want to work with people on these insurance with these populations, and a lot of us are the most vulnerable in society. And like I said, I'm lucky that I have some financial resources and I have been able to do some private pay so they can get at least a minimum of mental health services that they need. But a lot of us aren't that lucky. And the other issue we have is that there are a lot of roadblocks put in place, a number of different medical arenas that don't recognize the issues with people that have comorbidities have. So one problem that my family has is my oldest has a circadian rhythm disorder, and her sleep-wake cycles continue to shift. We are not able to get a lot of services. We're denied for a lot of services because her sleep-wake schedule does not align with the required times that the different providers, both medical and behavioral health, are requiring her to be there for services. And we are left with no alternatives. It's a constant struggle because we are not able to find providers that can work with us. She continues to get denied because she doesn't fit the criteria of a typical patient. So that's what I wanted to share, and I appreciate the time. Thank you very much.
Thank you, Denise, for sharing, and thank you to everyone that shared so far. Actually, I'm thinking with people joining in a little late, if we could take a moment to pop up the slide again and kind of go over what information we're kind of looking for today.
All right. Dan, do you have quick access to that slide?
And as we're getting that slide in up, I just wanted to just remind folks what we're kind of doing today. We're looking for information as we begin the process to implement the health equity bill, which would require some additional training for healthcare professionals. And we're just trying to gauge as far as like information, get stories from the community. And so these are the prompts, but please feel free to share the important information that you see that you would like us to hear. The prompts are: what does equity mean to you? What are your experiences with health inequities and how have they affected you? How can healthcare professionals improve so that they are providing fair healthcare? And finally, is there anything else Department of Health needs to take into consideration? Thank you, Dan. And we can continue. Ashley, thank you.
Okay, I have Cody. Cody Main.
Hi, here I am. So So I'm the community paramedic for the Walla Walla Fire Department, and it's a newer position we started back in May. So I've kind of got a crash course in some community health issues. I've been in Walla Walla though for 15 years. Just some of the things that I've recently seen in May or since May in my new position. I think one of the big things is just the lack of mobile services. I think that we expect everybody to get to an office or get to, I don't know, some sort of a clinic. You know, a lot of that, a lot of people aren't equipped to do that. A lot of people are also just left to coordinate their own care once they leave an emergency department or their primary care, but yet they don't have maybe the cell phone to coordinate that care. They might not have the mental capabilities of doing that. So there's some issues there. I think there's also some issues just within organizations. One thing that I think that I see consistently when I'm trying to help people is I think HIPAA is a good, it's a good thing by and large. I think privacy is important, but I think HIPAA also provides an easy barrier for lackadaisical providers and staff to use to not help people. So there's been several times where I've called just trying to, I knew the patient, I knew that they had an appointment, I knew the doctor, I knew where they had to go, what they were going for. I just needed a time to take a patient to the doctor, and HIPAA was thrown in my face as a barrier. You know, I knew every single thing about that person except what time they need to be at the doctor. So I think HIPAA is probably needing to be revamped. It needs to be looked at, and I know that that's more of a federal thing, but I think that that's important. The other thing too is I think that there are organizations who have these arbitrary barriers that are put in front of people that are really difficult. I took a gentleman to our local VA clinic here in Walla Walla the other day. He saw a clinician. He was found to be actively psychotic, is what the clinician said. They were looking to place him in a acute psychiatric unit, and they said that he was psychotic. They said he needed an APU, and then they looked at his computer and they said, "Oh, he makes too much money. He's not eligible for transport." So they were not willing to help this gentleman who's actually unhoused and in our community because he was dropped off here from another VA clinic, much like an unwanted dog in the countryside, and then drove away from. So I think there's these arbitrary, just silly rules that prevent just good intentioned people from treating people ethically and morally. So that's my spiel.
Thank you for sharing, Cody.
All right, we have Kristen Wilson Weinberg or Weiberg.
Thank you. Can you hear me? Can you
Yes.
guys hear me? Okay, cool. So I'm a public health nurse. I work specifically focused on testing and treating people for hepatitis C at our King County Needle Exchange. Something that I run into a lot is, well, lots of times our patients need to be sent to the emergency room for wound care. Many times I have such a hard time getting people to go to the hospital when they really, really need it, because they've had all these awful experiences of being treated inferior in an inferior way because they use substances and they have mental health issues. And it feels, I think training is really good, but it feels like it seems like every single hospital, I have some that have occasional good experiences, but a lot of the time they won't go because of the way that they've been treated in the past. And so I really want substance use and mental health care to be part of our inclusivity of being respectful to all. And I really appreciate the things that everybody else has said so far. And I just thank you for listening, and yeah, that's all I have. Thank you so much. Bye.
Thank you for sharing. Della, will you unmute and please share? We cannot hear you yet. All right. While you sort out the voice, we'll go ahead and go down to Rebecca, and then we'll go back to you, Della.
Hi, thank you so much for giving me the opportunity to speak about this. I want to talk about your prop number 3 about healthcare professionals and how we can improve healthcare. I am also a nurse, and I teach full-time faculty in one of our local nursing programs. And as a Hispanic woman, I have experienced, either me or my family, health inequities. But what I want to talk about is how we can stop frequently, even in nursing education, we talk about, we treat everybody equal, right? And we talk about cultural competence. And I would like to see the needle move toward getting away from this idea of that we've already checked the box, we've learned about these cultures, we know about this culture, and start moving towards learning about privilege and oppression and power within our healthcare system, so that we can begin to actually see real change and address systemic racism within our healthcare system, in hopes to help our communities of colors and decrease that health disparity. And I think that it's very vital to start addressing that, not just in continuing education, but also earlier on within our nursing programs. Thank you.
Thank you for sharing.
Hello.
Della.
I'm testing. Can you hear me?
Yes.
Yay, I fixed it. Hi, everyone. I want to thank you for having this open session and hearing all the stories. I'm actually a nurse who worked through the COVID pandemic and a local outbreak in Washington. I was the only nurse for 40 patients who had COVID. And the thing I'd really like to address is that, you know, for all of us, when I see how can healthcare professionals improve so that they are providing fair healthcare, there is no way for me or my cohorts, you know, on other shifts to provide fair healthcare in a situation like that, where you're the only nurse for 40 very sick people. And really, it's sort of the big elephant in the room, I think, is that this is due to who holds the purse strings, who holds them for training, who holds them for, you know, designating employees to take care of emergency situations, or even things like wound care and this and that and the other. If there's not enough staff, or if they're overworked, or they're fatigued, or, you know, documentation takes up 40% of a day. These are things that, you know, without the people who sort of manage, sort of having buy-in on equity and patient-centered care and caring and providing fair health care, you know, it's sort of, administration is trained to care about money, healthcare professionals are trained to care about the patients. These are very different goals. And so I think it would be important to maybe start looking at that and how we can work more closely together to be able to provide these things, a lot of which I hear people talking about, where I've been in those situations as a nurse, as the healthcare professional to the doctor, or just as a standalone, and been helpless. I've been helpless to the rules and regulations, or what, I was tasked to do that has nothing to do with caring for the patient's health. And that's what I have to say. Thank you.
Thank you very much. And Dan, will you go ahead and take the slide down for us?
Can I talk because I raised my hand and I cannot talk?
Not yet. We're going to be going through in order.
Perfect.
So,
Thank you. Sorry for that.
oh, no problem. Nas. I apologize if I'm pronouncing your names incorrectly as well.
That's okay. My name is Naz. Can you all hear me?
Yes.
Okay, wonderful. I just wanted to say, as a person coming from the Middle East, I have had many moments of healthcare inequity for the last 40 years in the Puget Sound area. I also served the city as the chair of Diversity, Equity, and Inclusion Commission for 5 years. So I also am a supervisor at the Community Health Center. So being at the receiving end and being familiar with the work of diversity, equity, and inclusion, and being in the center of being a part of a healthcare community, healthcare center, I see all the implicit bias and the unconscious bias that is happening. And I want to kind of piggyback off of what Rebecca and Della were saying. I think one of the most important issues that we need to look at in equity, I think is important I'm so sorry you took down the questions. So, the question was, how can healthcare professionals improve? I think it is very important for healthcare professionals to have training in the work of diversity, equity, and inclusion, and to understand all the institutionalized racism and structural racism that is part of the fabric of our society that we might be unconscious about. And it is also very important for healthcare providers not to hide behind like in a community center, I see that even though the conversation and the mission is to help everyone equally, I see how it is being, people are being discriminated against, and how people are just not being listened to or being written off because of where they come from, or being grouped in a addiction problem or mental health issues, and all the unconscious bias or maybe conscious bias that is driving this. I think is very important for healthcare providers to have training and lessons in diversity, equity, and inclusion. And I thank you for starting this conversation. And as we get more and more intentional about having these conversations, I think we can start to make a difference. But as someone started saying, that there are lives at stake here, and there are many people who are not getting the care that they need to. So I think it's imperative that providers get this kind of training. And as Della said, that we need to bring economic equities into the conversation as well, so that we do have enough care for the patients so that we can move forward. Thank you for your time.
Thank you. We'll go down to Melissa.
Can you, excuse me, can you hear me?
Yes, you can.
Oh, great. My name is Melissa DeCumos. I'm actually an optometrist, a colleague of Dr. Larry Jones. I wanted to speak on behalf of the Optometric Physicians of Washington, but specifically, I'm part of a specific task force that we created within the last year or two called the Diversity, Inclusion, and Access Task Force. One of our primary goals is to increase eye care to for people of color, people experiencing poverty, immigrant populations, and older Americans. Our association recently commissioned a research group, and the main reason we did that as an association was to expand our scope of practice, be able to provide more services for more of our patients. And what was really interesting and valuable information was that we learned that 1.9 million Washingtonians live in communities where to get to the closest ophthalmologist, it's at least 2 times longer than to the closest optometrist. This is particularly important for, especially for people that live in rural Washington. And when you look at those 1.9 million Washingtonians, more than 1 in 4 meet the state's definition of low income. 1 in 5 are people of color, and nearly 1 in 5 are over the age of 65. So I want everyone to know, and these are really interesting stories and in many ways heartbreaking stories to listen to. Optometry in Washington is trying to actively work towards supporting and promoting health equity. We're working on a bill with that. And to kind of also just say, based on some of the comments that were made today, I do agree that more providers need to be providers for public insurance like Medicaid and coordinated care. And I think that is a huge problem. That's a huge problem. And often, as I think Denise said, these are often the populations that are in need of the most help, and they can't find a provider to get that help. And so in general, I think that's a big issue, and I hope that optometry can help to address this particular issue. And thank you for having this conversation tonight.
Thank you for sharing. In the interest of time, we are going to have to limit. So after we'll do 2 more, and then I will encourage you guys to submit written comments or to attend another listening session. Melissa, you were next, or actually you just shared. Lolinda.
Yes, hi. I work for Delta Dental of Washington. I am the program manager for workforce diversity and inclusion, and what my job is to do is to try to increase diversity in dentistry. One of the things that I'm finding in this line of work is that there is not enough diversity in dentistry across the state, meaning that patients are not able to see dental providers that represent them or look like them from their community. This is a huge problem because that means dental cavities are on the increase, as well as oral cancer, because patients don't feel comfortable seeing providers that they don't trust. So therefore, treatment plans are not being accepted. One of the things that would be crucial for the state of Washington and for us as medical providers and healthcare providers, mental health, is to talk about trying to entice others to come from different states that are from a diverse community to come into Washington, or to educate our children about the importance of mental health providers and dental providers, because diversity is so important in all aspects of things. So that's what we're doing at Delta, is really trying to get into the communities to teach our kids about the importance of dental health. The only way that we're going to, combat this, the racism and discrimination, is to get more representation into the field, get more doctors that look like myself, like most of us, anyone that's from a diverse community. We talk about training. Training is fabulous. It's great, but we still need more providers that look like the communities that are diverse, even LGBTQIA, getting more providers out there from all backgrounds. So training's great, it's great, but we need more providers. And we also need to start to collect that data by adding race, ethnicity, and gender to the licensures of all medical and dental providers. So that way that information can be tracked. Currently, we do not have a way to do that unless a doctor renews his licensure in the state of Washington. But for dental and medical, we have no way. I'm a registered dental assistant, and I never filled that out. So I'm a diamond in the rough, and I'm proud of it. However, we need more that look like the diverse communities that are in our state. Thank you.
Thank you for sharing. Mustafa.
Hi, can you hear me, guys?
Yes, we can.
Okay. My name is Mustafa. I'm the Vice President of Iraqi Arab Health Board and also work as a mental health professional clinician at Lutheran Community Services. I also live as supervisor in Livingwell, Kent for the youth mental health. So most of our clients, there are refugees and immigrants and asylum seeker, and they are not have medical insurance. And this is what I saw for 12 years that I have been in Washington, or 13 years in Seattle, Washington. So they're struggling for that. As a provider one, they say, oh, you have Medicare or Medicare, and this is provider one, your insurance is not covered. So they don't know where to go. And they don't refer them to the professional things. This is for the provider one. For the dental also, most of the refugees and immigrants, they don't have been covered by the dental. So most of them, if they have the dental cover, just the filling and the extract. So if they want to save their teeth, or like, they cannot cover, and they cannot give out-of-pocket money because it's expensive to do the root canal and these things. So they struggle for that. And also the struggling with a language barrier, because nobody advocates for them. So they came to us or to me, and many times I feel I'm burnout because I cannot do it alone, to be advocate, to be provider, and then to be mental health professional at the same time. So we have lack of these things, the language barrier and education for the same language for the Middle East or this. Most of my clients, also the refugees, they are complain for their racism, and they feel inferior when go to the provider one. They say the doctor did not understand me, understand my culture, and they feel there's discriminations as they don't listen to them. So there's unfair in the health provider or injustice for that, especially for BIPOC and for Middle East community. The insurance is also not covered from them. Also, the other thing is lack of the mental health for the youth. We don't have the same language that we do. So that's what let me divert my professional, because I was physician in Middle East. So when I came here and I saw these suicidal thought and suicidal ideation, then suicidal attempt, and the commitment suicidal for the youth, not adult, because the adult is okay because our religion may be the Muslim religion that prohibits that. But when we lost 4 years ago, this young lady, she's 22 years old. I shift my to be concerned more about the mental health. So I participated as a member of the Community Health Board Coalition, and to work as to build a mental health clinic for BIPOC community. And that's why the lack of the mental health for the youth, and this is so important now also, we don't have the same language, because when you refer a client, he's 16 or 14, 15, to the American provider one as a mental health, they don't understand the culture. They don't, and that we feel deteriorated in the treatment goal and treatment plan for the client. Then they came to me through the community and I helped them, and we reach a good prognosis with the client, and, you know, to have from suicidal attempt, now we have, you know, young people, you know, guys, they are, you know, they don't have now, just sometimes suicidal thought, but they don't do attempt. And this is going to be a behavior maybe transmitted from, like, you know, our community. And I just want to prevent that. But when I feel alone and a provider on, they not, so many times I feel I'm burnout. The other thing,
Mustafa,
yes.
sorry to interrupt, but if you can wrap up your thoughts,
Yeah.
you've.
Yeah, because I write them in the paper, so it's just easy to me to write them. And also, lately, what's happened due to the stigma of the COVID, our community is afraid to say that is we have COVID, and they don't know where to go. So since the Department of Health at that time, they don't even have to provide them the mask. So we do our community, that is some lady that is sew the mask, we bought the fabric and we distribute that. And then we do the events of the test and then for the vaccination. But we work as alone, like Iraqi Arab Health Board alone, and we just see what are the resources, how can we provide the community the thing that is they needed at this crisis time. And now lately, this is the stigma of the COVID, especially for Omicron, and that they don't tell you unless the health situation is deteriorated, and then they say, oh, we have this. So I refer them to go this to see the provider one and these all like things. So thank you so for listening. I hope that I'm not take long time, but I should wrap it up. Thank you so much.
Thank you very much. And Rita, I think you're the last person who hasn't shared yet. If you would like to share, go ahead. And you are on mute.
Can you hear me now?
Yes.
Yes, okay. I'll make this brief. I feel like many of the points that I'm concerned about have been covered by a number of people. I won't reiterate those. My particular interest is in any way that the Department of Health can work with training, medical, dental, healthcare providing training facilities so that people get this training sooner, earlier, and that rather than trying to make an intervention into people's behaviors and perceptions while they're in the middle of very hard work. And it's not that I think we shouldn't do that, but I think that even better if we work to encourage and require in whatever way we can that a part of medical healthcare professional training focuses on equity and ways that we can increase the equity of the services and the behaviors and practices and institutions that have been building a lack of equity in. So that is my concern. And in particular, I think that that's something we can do with written materials. In addition to the training, just making sure that written materials are set up in such a way that they don't reinforce things like misgendering or pigeonholing ethnicities or the many ways that people get stereotyped and pigeonholed that I think really interfere with their getting quality health care. Thank you for this chance to share.
Thank you for sharing. I see maybe I'm missing, but I see one more hand up. Cody, man.
Yeah, I get to go twice. Hey, so one thing I think's really important, and I mentioned it in the chat, but I have to say it too. I think that, you know, we're all in an unprecedented time in our healthcare history, and nobody that's currently around, you know, remembers the Spanish flu pandemic or anything like that. And obviously, science has come a long way, but there's burnout, there's compassion fatigue, there's PTSD, you know, with all of our providers and everything. And I think that one of the, I'm not trying to give an excuse to any of the treatment that anybody's talked about or whatever. I'm a provider myself, and I try to give, you know, the utmost respect and dignity to people. But I think it's an important thing to look at, just the mental well-being of our providers, and try to you know, give them education, give them grace, and everything too. So I just think that that's a really important thing that we need to remember too, is that we're talking about some bad examples here and some things that shouldn't have happened, and I hope they never do again. But also, there's a lot of really good people out there that have done a lot of really good things in a very tough time. So I think we would just be remiss if we didn't think of that.
Thank you for sharing. And for other people who just put their hands up, we do accept written comments, or you can come to our next listening session. That will be next week on Thursdays during the day, or the following week, which will be the same day, same time. Please don't hesitate to contact us if you have any questions. We will always take written comments, even if you shared today. And then please let people you know about our listening sessions. I will turn it over to Ross and Hope, or to share a little bit more about what we're going to do in the future and timelines. And then we'll go ahead and close up tonight's listening session.
Thank you, Ashley, and thank you for everyone for joining, and thank you to everyone who shared. Just real quickly, as Ashley mentioned, we'll be having 3 more listening sessions. February 10th will be our next listening session at 10 a.m. And then February 15th at 5 p.m. and February 24th at 10 a.m. After our listening sessions are completed, we'll move to rules workshops, and those will allow us to go through rule language, draft rule language with everyone. Everyone will be able to ask questions, make suggestions, and we'll work through that rule language together. There'll be 3 rules workshops, March 7th, March 21st, and April 4th. And Gov delivery notices have gone out, and we can recirculate those or provide those dates for anyone that needs them. And then looking down the road a little bit further, we hope to file our notice of proposed rulemaking, which will include the proposed rule language in July, and then have the public hearing on that rule language in September. So that's looking ahead a little bit. Again, I just want to thank everyone for their time tonight, and I will send it back to Ashley.
All right, thank you again for your participation. There's a great question. Can we share the survey link with others? The survey link will also be going out to those who have participated via email. We have received some comments, and so you can share the link with others, especially if they participate, whether sending me an email or whatnot. And I hope that answered the question. And if you have any more questions, I'll stay behind to go ahead and further answer. So with that, I really appreciate you guys attending, and you all have a very nice night.
Ashley, this is Robin Naroon. Are we allowed to ask questions now?
Yes, if you have any questions, I will answer them. And if I don't know the answer, I will find an answer for you.
Yeah, my name's Robin. We've talked before. I'm with the Community Health Board Coalition. One of my questions is, there's a lot of rhetoric around critical race theory being taught right now. Have you thought about how to mitigate any chance of that coming up as we implement this curriculum?
I probably need to do more thought around it. A lot of, which you can tell, a lot of this is not necessarily planned, as we're really hoping for it to come up organically. We did speak a little bit about what to do if we get off topic or something's harmful, but no discussion specifically on critical race.
I do worry about that a little bit, but maybe I'm doing some anticipatory worrying, or maybe it's not a problem. Yeah.
I've done a lot of worrying and as well. What I can do, Robin, is I will make sure tomorrow that the internal team has a discussion about it, and then we can really plan around that.
And then one other thing I'd really like to say, if there's time, is that I'm really concerned that we will use a lens of like cultural competency, which doesn't, it doesn't address racism. It doesn't address poverty or colonialism or historical trauma. It's a very inadequate framework to use for health equity. It tends to be essentializing. It doesn't look at the culture of the dominant. And so what I'm, really asking is that, can we use the most critical of theories to get the curriculum out? Like, I'm hoping that the curriculum template will include anti-racism, and that we say the R word, and that we, we use structural competency and something like cultural safety. I'm just really concerned about it being watered down.
And those are all different things that we'll look at. And really, Robin, I encourage you especially to be vocal during our rules workshop. And also to add, I would like to reach out to you via email, and we can see if maybe we can schedule something further.
I would absolutely love that. I'm putting my email. You have it. We've talked before, Ashley. Quit pretending you don't know me. We've talked because I worked on the 5229. So I'd be happy to help with, because I would like to think about this and how we can support it.
Okay, perfect. What I'll do is I'll kind of reach out and sense what your availability is, and then try to get something on the books.
Thank you so much, and thank you for holding these.
Oh, no problem.
I'll say, I'll turn off my mic because I think there's still a lot of people here. I can't tell.
Do we have any other questions or comments? As soon as the core team leaves, the meeting will shut you out. All right, I really appreciate your participation, and maybe I'll see you next time. Maybe I'll hear from you in an email. Yep. Hopefully I'll see you at the rules workshops as well.
And the rules workshop is the March 7th, 21st, and 4th. Okay, yeah, I'll try to make it. Thank you so much.
Thank you so much. Have a great night.
Bye, Mustafa.
Bye-bye.
You guys have a nice day.